Hello, everyone. Have you ever heard of anti-allergic drugs such as cetirizine, fexofenadine, levocetirizine, loratadine, bilastine, or desloratadine? These medicines are commonly used to relieve allergy symptoms such as sneezing, a runny nose, itchy or watery eyes, and hives. In this video, we'll explore how allergic reactions occur in the body and how anti-allergic drugs work to provide relief. Before we can understand how anti-allergic drugs work, we first need to understand how an allergic reaction occurs. Allergic reactions are commonly triggered by allergens such as dust, pollen, animal dander, and in some cases, microorganisms or their products. When an allergen enters the nose, it penetrates the mucous barrier and reaches the underlying tissues of the respiratory tract. There, the allergen binds to and cross-links IgE antibodies present on the surface of mast cells. This cross-linking activates the mast cells, causing them to undergo degranulation and release the histamine stored inside their granules into the surrounding tissues. Once released, histamine diffuses through the surrounding tissues and binds to H1 receptors present on the surface of target cells. Remember this H1 receptor, as it plays a crucial role in the action of anti-allergic drugs. When histamine binds to the H1 receptor, it activates a GQ protein located just beneath the receptor on the inner side of the cell membrane. As soon as the GQ protein is activated, its alpha subunit, known as G-alpha-Q, dissociates from the protein complex. The activated G-alpha-Q subunit then moves along the inner surface of the cell membrane until it encounters an inactive phospholipase C enzyme, or PLC. As soon as G-alpha-Q binds to PLC, the enzyme changes from its inactive form to its active form. The activated PLC then moves along the cell membrane and interacts with a specialized membrane phospholipid known as phosphatidylinocytol 4, 5-bisphosphate, or PIP2. PIP2 enters the active site of PLC, where it is cleaved into two important second messengers, DAG and IP3. DAG remains embedded within the cell membrane and later participates in the activation of protein kinase C, while IP3 is released into the cytoplasm and travels deeper into the cell to continue the signaling cascade. After being generated, the IP3 messenger diffuses through the cytoplasm and travels toward the smooth endoplasmic reticulum. If we zoom in even further, we can see specialized calcium channels, known as IP3 receptors, embedded within the membrane of the smooth endoplasmic reticulum. Each IP3 receptor is composed of 4 subunits and normally remains in a closed state, trapping a large amount of calcium inside the endoplasmic reticulum. As IP3 messengers bind to the receptor sites on all 4 subunits, the receptor undergoes a conformational change, creating a central tubular pore through the channel. This newly formed opening allows a massive amount of stored calcium ions to rapidly flow out of the endoplasmic reticulum and into the cytoplasm. As a result, intracellular calcium levels rise dramatically. The rise in intracellular calcium acts as a powerful signaling event inside the cell. However, the effects of this calcium signal depend on the type of cell in which it occurs. In the cells of the nasal mucosa, calcium-dependent signaling promotes the production of mucus and stimulates sensory nerve endings, leading to sneezing and a runny nose. In the ocular conjunctiva, it contributes to itching and excessive tear production, resulting in itchy and watery eyes. In cutaneous tissues of the skin, it triggers responses that lead to itching and the formation of hives. And in the smooth muscles of the airways, increased intracellular calcium promotes muscle contraction, causing bronchospasm and narrowing of the airways. Now that we understand how an allergic response is initiated, let's see how anti-allergic drugs work to interrupt this process. To better understand their mechanism of action, we'll use cetirizine as our prototype drug. When you swallow a cetirizine tablet, it travels down the esophagus and enters the stomach. There, the tablet begins to disintegrate and dissolve in the gastric fluids before moving into the small intestine. The inner surface of the small intestine is covered with millions of tiny finger-like projections called villi, which greatly increase the area available for absorption. As the dissolved cetirizine passes through the intestine, it is absorbed into the capillaries present within these villi and enters the bloodstream. As soon as cetirizine enters the bloodstream, approximately 93 to 95% of the drug temporarily binds to albumin, the most abundant protein in the blood. This binding is reversible, meaning cetirizine continuously binds to and unbinds from albumin as it circulates throughout the body. However, one important exception is the brain. Unlike first-generation antihistamines, which are highly lipid-soluble and can readily cross the blood-brain barrier to bind H1 receptors in the central nervous system, cetirizine behaves differently. As a second-generation antihistamine, cetirizine is predominantly water-soluble and exists as a zwitterionic molecule, carrying both positive and negative charges. These properties greatly restrict its passage across the blood-brain barrier. As a result, cetirizine primarily acts on peripheral H1 receptors, while causing significantly less drowsiness than first-generation antihistamines. Now, let's look at the primary mechanism of action of cetirizine. Earlier, we saw that histamine binds to H1 receptors and triggers allergy symptoms. Cetirizine interrupts this process before it can even begin. By reaching the receptor first, cetirizine binds strongly to the H1 receptor and stabilizes it in its inactive state. In fact, cetirizine acts as an inverse agonist, meaning it not only blocks histamine from binding, but also reduces the receptor's basal activity. As a result, the H1 receptor remains inactive, the GQ signaling pathway is not activated, and the downstream release of intracellular calcium does not occur. Without this signaling cascade, the cells fail to generate the responses responsible for allergy symptoms, helping to prevent sneezing, a runny nose. We've seen how cetirizine produces its anti-allergic effects, but how is it eliminated from the body? Unlike many other drugs, cetirizine undergoes very little metabolism. Less than 5 to 8% of the drug is metabolized, and it experiences minimal first-pass metabolism in the liver. This is because cetirizine is predominantly water-soluble, allowing most of the drug to remain unchanged in the circulation. As blood continuously passes through the kidneys, cetirizine is repeatedly filtered by the millions of nephrons present within them. As a result, approximately 85 to 90% of the drug is eliminated unchanged through the urine, while the remaining fraction is excreted through feces and other minor routes. This gradual elimination continues with every circulation cycle until the drug is eventually cleared from the body. That was the complete breakdown of allergic reactions and the mechanism of action of anti-allergic drugs. Before you go, I'd like to ask for a small favor. If you enjoyed this video, please consider liking the video and subscribing to the channel. Creating a single 3D medical animation takes days of work, from research and animation to rendering and editing. Your support helps me create more detailed and higher quality medical animations. Thank you for watching, and I'll see you in the next video.